Welcome to this clinical update. Today, we are breaking down a monumental shift in neuroradiology, the 2024 to 2025 McDonald criteria for multiple sclerosis. For years, we have operated under the 2017 framework, focusing on the physical demonstration of lesions across time and space. However, the new criteria represent a fundamental move toward a biological diagnosis. One of the most immediate changes for the reporting radiologist is the expansion of anatomical territories. We are moving from 4 classic sites to 5. The optic nerve has officially been integrated as a 5th topographic site for satisfying dissemination in space. This means that if you identify T2 hyperintensity or enhancement on dedicated orbital views, it carries significant weight. What is truly revolutionary here is that non-imaging data, such as optical coherence tomography showing retinal nerve fiber layer thinning, can now satisfy this anatomical tick box even if your MRI of the orbits is negative. This allows for a much more holistic approach to the space requirement, acknowledging that our magnets don't always capture the full extent of the initial damage. Moving into advanced sequences, the new criteria finally bring the central vein sign and paramagnetic rim lesions into the fold as optional, but highly recommended markers. As radiologists, we have known about these for years, but they are now official tools. If you see the rule of 6 or more lesions with a central vein on SWI, the specificity for MS becomes nearly absolute in your report. Similarly, the presence of even one paramagnetic rim lesion, representing a chronic active inflammatory edge, is a powerful red flag for MS and a predictor of a more aggressive disease course. If you are not already including a susceptibility-weighted sequence in your MS protocols, now is the time to start. These markers help differentiate MS from mimics like migraine or small vessel disease. Perhaps the most significant clinical shift is the virtual death of the weight regarding dissemination in time. We no longer necessarily need to see a new lesion on a follow-up scan. Under the 2024 criteria, positive CSF markers now including kappa-free light chains can serve as a complete substitute for dissemination in time. If a patient has two typical lesions and a positive lab, it is MS. This even extends to radiologically isolated syndrome. If you find incidental lesions that meet the space criteria and are supported by these biomarkers, a formal diagnosis can be made before the patient ever experiences their first clinical attack. This allows for earlier intervention. We are shifting from reactive imaging to proactive biological identification of the disease state. Finally, the new criteria provide much-needed safeguards for our older patient population. The 2024 update mandates stricter thresholds for those over age 50 to avoid the vascular trap. In these cases, we are encouraged to ignore deep white matter lesions and rely almost exclusively on highly specific sites like the spinal cord or the presence of the central vein sign to confirm the diagnosis.